Hi and welcome to episode 18 of Beating BDD. It's been a while since you've heard from us, so to make up for it, we've got a real treat for you today, an interview with Professor David Veale. David is a leading specialist in BDD, based at the South London and Maudsley NHS Foundation Trust and at the Priory Hospital, North London. And he's with us to answer questions from people with the condition. I hope you find this interview as interesting as I did, and do let us know if there's anything you'd like us to ask him another time. Hi David, and welcome to the podcast. Thanks ever so much for joining us.
Thank you.
How would you say pandemic is going for you? Has it affected your work a lot? We're in third lockdown now. What does that mean for you and your patients?
Well, it's been pretty disastrous. I think we're just all waiting for more tsunami of mental health problems, which is just going to get worse. The way I think everything's being covered up at the moment. And certainly our anxiety residential unit got closed down, and a lot of our work is being done remotely. It's not very satisfactory at all. And I think particularly for people with BDD, some people it seemed to be a blessing at first. They can legitimately wear a mask and people are encouraged to stay at home and things like that. But certainly some people with BDD, find it more difficult to connect therapeutically over Zoom or Skype or whatever. It's just generally more difficult for them. So look, we're desperately wanting this pandemic to end and to get on with things properly.
Yeah, well, imagine particularly things like Zoom have proved really challenging, I think, haven't they, for people who just, even people who aren't used to, who don't have BDD, who just aren't used to seeing themselves quite so often, are starting to register dissatisfaction with their appearance. So it would be really helpful, I think, for listeners to just have a sort of précis of your background and how you came to specialise in BDD.
Well, I trained as a psychiatrist at the Maudsley Hospital, and that was particularly under Professor Isaac Marks at the end of my training. And I knew I wanted to specialise in cognitive behaviour therapies for anxiety disorders, but they're actually, if you do that as a psychiatrist, it's very difficult to get the right sort of consultant post for that specialism. So it's about 1991, about 30 years ago now, when I escaped to the private sector and ended up as a consultant at the Priory, North London. And soon after, I think I first got that post, I'd admitted a patient with BDD who was in his early 30s, married with a child, and he'd become completely preoccupied with his wrists and forearm. He'd been admitted for about just a few days when he took his life at the local railway station. I think that made a big impression on me because so little was known at that stage about this condition and how to manage it. There were only a few researchers at that time in the world, like Kathy Phillips, who were publishing in this area. And so I think that really influenced me in wanting to really have a better understanding of BDD and how best to treat it. So we went on from there, starting to do sort of research and so on. We developed a model of self as an aesthetic object, and we went on to try and develop it as a treatment protocol, and did one early controlled trial, and then subsequently did lots of other smaller studies and then another controlled trial. So I think that's how I got into it in the early days, when there was just nothing on it and we just really wanted to learn more about it.
And now that you are specialised in it, what keeps you doing it? What gets you out of bed in the morning?
Well, I think people with BDD get a real tough deal in life. And my interest has not been focused exclusively on BDD. It really is part of the community in OCD and related disorders like BDD, health anxiety, and so on. So I was a trustee setting up OCD Action about 1992, and then the BDD Foundation about 2012 or something, and always helped in trying various ways in conferences and so on. So it's still not understood that well. It's still treated poorly, high rates of suicide. So we need to keep going. And if you're going to be a national specialist, it's your role in life to really do that sort of research.
Keep banging the drum, yeah.
Keep banging the drum.
What would you say has changed since you first started treating the condition? Because things aren't perfect, but they sound as if they're definitely better than they were maybe 20 years ago.
The problem is, I think everything moves so slowly in the world of BDD. I think awareness has increased, but I think a lot of people are still very confused between sort of body dissatisfaction and BDD. I think eating disorders still dominate the field, and it's still very difficult to get a foot in the door, really. I think mental health practitioners are certainly more confident about recognising BDD, I think psychiatrists are better at treating medically. That's the sort of medication, that's sort of an easy part. I think there is better training in CBT. I don't think always the quality of CBT is always that good. I don't think it always follows the protocols that have been shown to be helpful. I think treatment is a bit more successful, but it's still very difficult to treat. And I think that the key things are really to try and help people get help early on, because obviously the longer goes on, the more difficult it is to treat, and you collect other problems and so on. So it's still a long way to go.
If you were to imagine someone coming in and you were able to kind of give them the ideal, the dream treatment, what is the kind of best practice treatment? And also, how do we know that it works?
Well, the best practice treatment is either cognitive behaviour therapy, which is specific for BDD, or an SSRI. And usually when people are more severe, it's best to combine it. And if that doesn't work, it's usually because you need a more intensive program. And I think one of the difficulties often people struggle with is they sort of know what they need to be able to do. It's more about getting the right support to help to actually do it in the moment, as it were. It's often transferring from the clinic into the real life.
I imagine, as particularly with something like BDD, because it's so, you believe it so strongly when it's happening, that actually being able to apply the things you've learned is really challenging right in that moment, isn't it? That's the big difficulty. Yeah. Are you currently working personally on any research you think could be of interest to listeners or might help them in the future?
I suppose the things I'm really excited about are more things we're still trying to get funding for. Mm-hmm. So what I want to do is a study on psilocybin in magic mushrooms, as it were. Oh, wow. So this is a psychedelic. And it's interesting, I've sort of come full circle. I remember as a medical student, I managed to get an interview with R.D. Laing when he was in Hampstead. He was still quite interested in LSD and psilocybin in those days. And these were like one-off trips. And it's very interesting because then became a class 1 illegal drug. So it's very difficult to do research in now. You can, but it's very expensive. There are so many things you have to do to comply with the licenses and so on. But there is some very interesting small studies done on people with resistant depression and PTSD and even OCD, where people have managed to help them to get out of their head and to really stop the ruminating and everything else. And this is just like a one-off taking of this particular psychedelic and so on. So it is interesting. And I think that, and then it can be combined with the therapy. It's something we'd like to do, but it's just going to take time, I think, to get the funding for it.
I saw on your website as well as you've got some interesting pieces on there about the gut biome.
One of those things which, well, I guess the area of sort of nutritional psychiatry is interesting psychology. There's really lots of interesting links between your gut and the brain. And most of the research so far has really been done on the gut, your physical health. But there's just as much relevance for your mental health. And the great thing about this is that there's lots of research now looking at things like depression and how some of your microbiota is different, that it's got more unhealthy bacteria, shall we say. And that if you transfer those bacteria from depressed patients into germ-free mice and all controls, you'll find that the mice that's received it from people with depression become more withdrawn and inactive and so on. Really weird stuff. So it'd be great to do that sort of research and then see if by diet or other interventions can then help improve symptoms of BDD and OCD and so on. But again, it takes a lot of time. And it's just another angle. I don't think it's ever going to cure these things, but I think it could be another part of the jigsaw, because we know that people's diets become increasingly less healthy, should we say, in terms of more processed foods. And the key thing these days is to be out eating diversity, a range of vegetables and legumes and pulses and things, and probiotics, prebiotics. And this is just not really in people's diets these days. Keeping under the radar. So it's just great stuff that we could do. The other thing we're looking at is lip fillers.
Oh, yes.
So
in what sense?
This came from a teaching I was doing to cosmetic practitioners who do mainly Botox and lip fillers and so on. And they were very interested. They meet a few people with BDD. But what they really wanted to know is how to cope with mainly women, of course, who want to have their lips overfilled. It's almost redefining beauty. And I really didn't know anything about this at all. But there does seem to be quite a culture of women who are having over-treatment, overfilling. They look a little odd to me. Yeah. But what we're doing is comparing women who've got overfilling against women who've got standard treatment, as it were, and seeing what the differences are. Do they have BDD? Do they have difficulties in relationships and things? Is this like a sort of male body dysmorphia disorder around muscles and things? Because it's just a whole new area.
That will be very interesting to see, because you wonder whether there's an element of, it's not necessarily that people with BDD want to have the giant ones, it's just that they're not recognising that giant is giant because they think they have an irrational view or an inaccurate view of the problem to begin with. Fascinating. In terms of treatment then, how do you see treatment developing, or how would you like it to develop, I guess, more pertinently?
One of my interests is in compassion-focused therapy, work that's being developed by Paul Gilbert and so on. I think that's very relevant for BDD, particularly where there's lots of body shame and so on. And when you're doing exposure and experiments to test out your fears, you've got to feel safe. Many people with BDD don't feel safe. You need to be able to perhaps enhance that ability to feel safe, either with others or with yourself. So the idea is, can we try and develop ways of that self-compassion and feeling safe? Because obviously many people with BDD are very self-critical and shaming themselves all the time. So just not feeling safe. It's crucial to develop that sort of aspect, I think. It takes time to reverse the pattern of self-criticism and trying to develop more that sort of self-compassion, feeling safe with yourself.
Yeah, and it's so easy to do it for other people when you twist it around and help other people. It's really easy to have compassion for them, isn't it?
But not yourself. Yeah. You don't deserve it.
Yeah, you're not worthy.
That's right.
So for the rest of the interview, I thought I'd put some questions to you that we've had from the BDD community and listeners of the podcast, which are a really interesting, varied range of questions. And I'm just going to read them out anonymously. So the first one is, how does BDD affect the way you see yourself in pictures?
Yeah, I've often thought about this, and it's really difficult because you would like some sort of machine that helps us know exactly what that person can see compared to reality. When you're looking at a picture of yourself, or looking even at yourself in the mirror, it's probably not what you see is what you get. Remember that old acronym that you used to get for computers, as it were? Because it's clearly going to be, we're all, biased by our emotions or past experiences and so on. We somehow develop a felt impression in our mind's eye as to how we look. So that felt impression, the only way we've really managed to understand that felt impression is to ask people to do a self-portrait. When you get a self-portrait, you can see that there's a massive discrepancy between how individuals see themselves and what they actually look like. This is the problem of then seeing yourself as this sort of aesthetic object, that you define yourself through that particular felt impression. Often certain features become very exaggerated or distorted in some way. So something is going on, and we think it's probably influenced by past experiences, especially things like being bullied and so on. And there's this massive emotional bias in terms of shame. But how we really get to inside the mind and understand what that person is experiencing, it's very difficult at this stage.
Fascinating, yeah. It actually is related to another question I was going to ask you later, but I'll ask it now, actually, which I found really interesting. So actually, I've experienced this. And it says, is it common for people with BDD to have some days where they think they actually look good? And if so, do they have BDD?
Yes. Look, that is the experience of people with BDD. I can't possibly say that. You can't possibly have that. That's the experience. That's the experience. So, of course, it is possible. I think it's usually perhaps in people who are in recovery or moderate BDD. But no, I think often what happens is that the body image is not stable and there's uncertainty around it. So that mood, I'm sure, will influence that in some way.
That's so interesting as well, because that would contribute to not feeling safe. If you're completely thinking all the time, my aesthetic is all, and I can't trust my aesthetic, then you're not going to feel safe within yourself.
I mean, obviously what we want to move people more towards is not rating, not judging yourself with your appearance, but the appearance is just one aspect of you.
And the next question is there any research into BDD sufferers who've also experienced bullying? And if so, what sort of treatment is recommended for helping them to deal with the impact of being bullied? And it's actually in 3 parts. The final one is, should it be dealt with before undergoing BDD treatment?
Well, certainly it's a very common narrative. Certainly starting off feeling different as an adolescent. It could be because of things like your sexual identity or dyslexia, or because you've worn glasses, or you've had acne, or there are all sorts of things that make you feel different. And so people with BDD often report that they've been bullied or teased, probably at least 40 or 50%, I think, either about their appearance or about themselves in general. And that's more common than adolescents without emotional problems, although it's quite still a common problem for adolescents with depression or social anxiety and eating disorders and so on. So I don't think it's specific to BDD, but there are certainly a good third of people, I think, with BDD who have very specific memories of being teased or bullied about their appearance, and it seems to be emotionally linked to the way they feel about themselves now. I just came to the conclusion that actually adolescents are bastards. And of course, it's much worse now, social media and so on. So it's not just adolescents, it's everywhere.
And in terms of treatment, do you think that the bullying then is something that would be tackled, or the impact of the bullying would be tackled as part of the BDD treatment? Or do you think it's something that person would need to look at first?
Well, this is something Rob Wilson did as his PhD and supervised. So that we did use something called imagery rescripting to try to help people with BDD who had these aversive memories of being teased or bullied and so on. Others have said, well, we could also use things like eye movement desensitization, reprocessing EMDR. So it's not actually usually a trauma in the way that you define a trauma for post-traumatic stress disorder, but it's clearly an aversive memory. Some of the interventions that are used for that, PTSD, in these sorts of problems as well. When would you do it? Well, we usually suggest doing it early on in a treatment if it's thought to be relevant, because it doesn't usually take up too many sessions.
Good, thank you. Next question. Do you have any advice for someone who's so ashamed of their BDD that they haven't told any of their friends or family?
So I think this is very important because you need the support of friends and family. I would ask that person, well, what's the worst that can happen? And perhaps try and predict different scenarios. Now, normally, if you can predict the worst case scenarios, you try to role play to prepare for it. If you really think people are going to laugh at you or humiliate you in some way, I think that's highly unlikely. I mean, it's possible, but I think it's highly unlikely. Think about how you would prepare for it and actually imagine speak out aloud, what you would say to that person when they say the things that they're going to say. Because I think it's very important to be able to say to your family members and friends, this is what I think I'm suffering from, this is how it affects me, I'm going to be seeking help, and I'd really appreciate your support. Because that is the first step, I think, because it does require courage. Courage means doing things uncomfortably. It's not going to be doing it. So I'd strongly recommend that try to reach out, to really connect with those friends and family. What being human is, really.
Is it common for people with BDD to want other people to find them extremely attractive? Is it just because they experience one extreme that they yearn for the other?
In my experience, most people with BDD just want to be able to fit in. They just want to be normal. They don't want to stand out. We did explore this in the study once with something called self-discrepancy theory, where you're looking at the discrepancy between how you see yourself and how you'd like to be. So most people just want to be fit in. They don't want to, and there are a few people who want to be able to be outstanding, really fantastic and attractive and everything, perfect and admired. But they're a minority on the whole, a small minority. But the thing about all emotional problems, there are every type, every sort. There's no one type.
It's interesting that you say that, though, because perfectionism is such a big part of conditions like BDD, isn't it?
Not so much, we think. For some people, it's not so much about being perfection. If you see yourself as already very defective and ugly in various ways, all you just want is actually to be able to fit in and be normal. You don't necessarily want perfection.
Yeah. It'll be interesting to see if that remains the case, given that we do seem to be in an increasingly superficial sort of distorted world and where no one's really putting up real pictures of themselves anywhere. Reality is becoming distorted all the time.
Yes, but I'm not convinced that such individuals have BDD. Maybe body dissatisfied, have very unrealistic ideals and expectations and so on. I mean, one of the problems in body dissatisfaction and BDD, of course, is the role of comparing, always trying to rank yourself into where you are with this one particular domain of appearance. Of course, you're much more complicated than that, with many different bits to you, and it's not very helpful to compare and rank. It's very understandable because you see that as the most important thing, as a way of trying to reduce the sense of threat. But you want to know where you stand. But the problem is there is no threat. You find yourself comparing and ranking and ruminating about it, and of course it just maintains and feeds the preoccupation.
Yes, a hideous cycle. How are BDD and social anxiety or inferiority complex related?
Well, this is related to either internal shame or external shame. So someone with internal shame is failing to meet their standards, where they feel ugly about a particular defect, and they've got a sense that they know that others don't care, or it doesn't matter what they think, or they can't really see necessarily what they see. It's almost like, if you're on a desert island, no one around, and you'd still be checking in mirrors and very distressed and preoccupied because you're constantly judging yourself. That would be internal shame. And external shame is more to do with your fears about how you appear in the eyes of others. In other words, you believe that others are judging you. And obviously many people with BDD have got a mixture of both internal shame and external shame. But some people are more towards one end rather than the other. But true social anxiety would not just be external shame, but it would focus on more competence or worth or performance. You're worried that people can see that you're shaking or something, or boring, things like that. Whereas, of course, true BDD is the fear about other people evaluating and judging you as being ugly, and so on. So true BDD is focused only on appearance. Social anxiety disorder and low self-esteem is more focused on competence or worth. So obviously the two do get mixed up. There's often a mix of the two, but usually with BDD, it's mostly largely to do with your appearance.
And inferiority complex was the third thing that the listener mentioned. Is that just a catch-all term?
It's not really it's a sort of common popular term. Its inferiority just relates to your belief about yourself being inferior compared to others. It's back to this comparing and ranking of yourself. So you keep yourself down the bottom and others are always up here. It's more to do with that shame, particularly external shame, and how you believe that others see you.
Indeed. Is it normal for BDD symptoms to intensify when a woman is on her menstrual cycle?
I don't think there's enough research on this. So we know that mood is worse in the premenstrual period, perhaps for some women. So it's not surprising if BDD also gets worse during the premenstrual period. And so I think you'd need to find a good gynecologist who specialises more in PMT, and that may be something that can be helped in the premenstrual period.
Are there any studies into cosmetic surgery in BDD? Do we know its effects on the disorder?
Well, the problem is that in specialist services and clinics, we see people who, at least about a third, who already had cosmetic procedures and have been dissatisfied, or they still have symptoms of BDD despite other surgery going on. So that's why it's usually recommended that it's not helpful to have cosmetic procedures. The problem is that it may be that if we did a proper study in cosmetic surgery clinics, that you'd get a lot of people with mild BDD who may be satisfied with their problems, their issues. Nobody's ever really been able to do that in a good, what we call prospective study, and really follow people up who got measures before surgery, procedures, and after, in a long-term follow-up. And certainly maybe there are some procedures that are safer than others, things like breast augmentation or pinoplasty, pinning your ears back, things like that, may be safer because they're more obvious procedures, as it were. But things like rhinoplasty or nose jobs seem to be quite risky, even for people without often BDD.
Yeah, so you often hear about people having them done again and again.
It's a complicated area. If by the time you're actually coming to see people for help with BDD, it's really not usually a good idea. You really need to commit yourself to getting recommended treatments for BDD.
Absolutely. Next question is, because I also have bipolar 2 disorder, I can't take SSRIs. Are there other medications that can be helpful for BDD?
SSRIs are not an absolute no-no for bipolar disorder. If you're also taking a mood stabilizer like lithium and so on, or things like creatine, these can help prevent any deterioration or relapse into mania and so on. So it's something certainly to discuss with your doctor, I think. And
the next question is actually almost like the other side of that question, which is, what do you do if CBT isn't for you? You do hear about some people saying it just doesn't work.
The question is, what has been the quality of the CBT? Did it follow a protocol like in our trials or in Sabina Wellham's trials? And did you get, with your therapist, a good understanding of what the problem was and what needs to be done? Were you able to really practice those things with good homework, have clear goals? So you really need to go into a lot more detail about what the obstacles were and where did it go wrong. And there is a clear, certainly I'm talking now in the UK, there's a clear pathway for national specialist services where right at the very top, if you've had 2 lots of trials of CBT and 2 lots of SSRIs at the sort of maximum tolerated dose for at least 12 weeks or so, and you're still severe, you can get referred, and there's no problems of funding and so on, to a specialist service and receive specialist CBT, or sometimes in a residential unit like ours at Bethlehem, or even an inpatient unit at the Priory or Springfield, so that these are clear pathways if it hasn't worked the CBT for you.
Now, that's very interesting. There's actually only one more listener question, which is, what does acceptance mean in BDD and how important is it to the recovery process?
Well, acceptance is usually come from a branch of CBT called ACT. So accept, that's sort of acceptance and commitment therapy. So acceptance involves bracing your emotions and that body image and memories without judgment or trying to get rid of it or rationalize it, just leaving it so that you can then do things in life which are important to you. You're not doing things despite those images and thoughts and feelings and so on. So it is a good theoretical concept in trying to diffuse yourself from that felt impression, how you look in your mind's eye and so on. It's a very difficult thing to do. It's a great concept, but the key thing is not about judging yourself to be looking good or bad, or whatever. It's about not judging and trying to still act upon your values and things which are important in your life, despite it. In other words, not getting into the content of your stuff.
Very interesting. Is there anything that you particularly want to say while you have the floor of beating BDD, or any advice that you would want to give out to listeners out there who might be struggling?
Well, I think the most important thing is don't give up. We recognise, we all understand how tough it is to have BDD, but you've got nothing to lose by testing out your fears and acting against them. So it's not always going to go right. One of the problems, I think, in BDD is being disconnected, that you're not really part of the human community, as it were. And so it's such a terrible, important thing to try and connect with others and develop those sort of skills and self-compassion and so on, because it takes time. And we do need, as we talked earlier about the support of friends and family and so on. And just to be able to say to people that I'm feeling down today or whatever it is, and can I have a hug? Really trying not to focus on, therefore, what you look like, but really trying to focus on what's important in your life, trying to do the things in life which are important to you, despite what you think you look like, because it's not something that is an issue for others. And I know that's very difficult to believe because you're very much in your own head and self-focused and got this very picture in your mind that seems very real to you, but it's such a leap of faith to be able to sort of not go along with it.
Fabulous. Thank you so much, David. It's been really interesting to talk to you. Predictably, maybe we'll get you back on one day when the world starts up again, if it ever does.
Okay. Thank you.
Thank you very much. Thanks very much again to David for taking time out from his busy schedule to answer our questions. To hear more episodes, just search for Beating BDD on major podcast apps and on Spotify. You can also leave us feedback by following the BDD Foundation on Instagram, Twitter, YouTube and Facebook. I'll be back with another interview soon. In the meantime, remember that this podcast isn't therapy, so please do seek help from a trained professional. Thanks for listening.